Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning. Chest.
Today's lesson will be on chest x-rays. We're going to discuss some patient needs before we actually begin the procedures. With chest x-rays, this is the beginning of your positioning career basically in the RT program. And there's some preliminary information that you will apply to all patients. First of all, any patient that is in a early adolescent stage, under the age of 40, childbearing age, which might be from age 10 up, it's very, very important that you use protective shielding, lead shielding over reproductive organs. That will be a constant requirement of any exam that you're going to position, and that's shielding the reproductive organs of childbearing age and younger people. In the case of women, if you have a female patient in childbearing age, it's very, very important that you ask about the possibility of pregnancy. If there is a possibility of pregnancy, you do need to confirm with the referring physician that they know that the patient is possibly pregnant and that the chest x-ray should proceed. In some cases, the chest x-ray may be canceled, or else you will take special precautionary measures to protect the unborn fetus. Then it's very, very important to talk with your patients and analyze some history. Why did they go see the doctor? What were their symptoms? Are they having pain on one side or the other? Because normally you take a PA projection and a lateral projection. Routinely it's a PA and left lateral, unless there is history of pain or a tumor, pneumonia, something that involves the right lung. The rationale behind that is if there is no symptoms or no history, the left lateral is used to get the heart closest to the film. It will be less magnified that way. The heart is a main focus area. However, if there's history of pain, say, on the right side, we need to get the right side closer to the film for the lateral, as it will be better demonstrated. So 80% of the time it's probably a PA and a left lateral, 20% of the time PA and right lateral, and the only way you'll know for sure is if you ask your patients. I've put some supplies out into our room that I would like you to look at now in getting ready for a chest x-ray. You will need 14 by 17 cassettes. You will need measuring calipers. You will need left and or right lead markers. And you will need a protective shield. This happens to be an apron. You might need to use a strip of lead to protect the reproductive organs. Having supplies readily available is a must. Okay? Now we're going to talk about our patient. Our patient is, let's say, in the waiting room and they're in street clothes and we need to get them dressed. There's some communication issues that you do want to address with the patient. So we're just going to show you now. We're going to call our patient in. And I have a requisition in front of me that has the patient's name, identification information, and it says chest x-ray. I'm going to go to the waiting room. Drea Shoemaker?
Yes.
Would you come with me, please? May I call you Drea today?
Yes, you can.
Okay. It's important to call your patient with their last name first, and then out of courtesy you can ask them if it's okay to call them by their first name. Most of the time it's okay to call them by their first name. If not, you stick with Miss Shoemaker. And this is Drea, class. She's a second-year student, and she'll be assisting with the demonstration today. When you talk to your patient, talk slowly, separate your instructions, watch for your body language and watch for their understanding. You can watch their eyes and their body language to see if they understand. You've got to remember, a lot of these people are elderly. They're sick, they're dealing with bad news, and they may not be thinking properly at that time. So be alert to those messages that you might get from their eyes and their body language. Okay. Drea, I've got a gown here. It's a patient gown. we're mocking today. I'd like you to put this gown on, Drea. I will need everything from your waist up off, including your underwear, and I would like it to open in the back.
Okay.
Okay? Usually there's a robe or something available in a dressing room as well, so you can offer that to a patient for warmth as well. So give your patient the instructions, offer them a robe, and tell them that you'll be back in a couple of minutes. So again, everything from your waist up off, and the gown opens in the back today. Okay? I'll come for you in just a few minutes. We're going to focus on the room setup now. You're going to use a wall bucky. This is a very standard example of a wall bucky. Here's your X-ray tube, and you can't see from the angle of the tube right now, but over on the floor here we have a mark on the floor that will tell the technologist that the tube should be at 72 inches. At 72 inches source image distance, 72 inches SID. Very important to have 72 inches whenever you can. That will minimize the magnification of the heart and prevent the appearance of engorgement of the large vessels. So 72 inches. And whenever possible, you need to do the patient in an erect position. That allows the lungs fields to drop down further to get full expansion. And I like to set my room up before I get my patient. I set my tube to 72 inches. And then we have marks on this wall bucky. It's extremely important that you be transversely centered. This line centered with that line on the wall bucky. If you don't, if you make that mistake and you have that appearance, we're only off a couple of inches, but it will mean that you repeat. You'll have to retake this X-ray because you will have grid cutoff. Okay, so that's a mistake you do not want to make. Make sure you are transversely centered. And I center this line here in order for me to determine the amount of collimation. This is the 14 by 17 framework that we will be focusing on today, and the light needs to be just within those marks on this cassette. This is manually collimating to your field size. Most hospitals have automatic collimation. As soon as you put the cassette in the bucky tray, the collimator shutters come down on their own. That's hospital work. Many clinics, private doctors, they will not have the automatic collimation. It's about $10,000 extra on the tube unit. Okay. You will get a 14 by 17 cassette from your supply cupboard, and we're going to put the ID blocker to the top. I want you to picture the shape of a patient's lungs. Apices are at the top. They're less wide, and the lung angles out to the costophrenic angles. The wider portion of the lung then being at the lower edge of the cassette. That's our rationale for putting the ID blocker to the top, because the lungs are less wide and more wide. I will get my L or my R marker now, and I'm going to put it just within the film's edge on the left side. The patient will be facing the wall bucky like this, and then the left marker will match up with the patient's left shoulder. That ends the room prep. Again, 72 inches SID, 14 by 17 cassette, ID blocker to the top, in the wall bucky, collimate to the 14 by 17 field, and put an L or an R marker on there. If you were choosing an R marker, you'd put the R marker on this side. Okay? We're now ready to go get our patient, assuming that they're dressed. Hi, Drea. How are you?
Good, thank
Okay. Again, Drea is in a gown, but we're just mocking this today. Drea, have you ever had a chest X-ray before?
No, I haven't.
You haven't. Well, let me explain the procedure to you then. We're going to take two pictures. You're going to be standing at the wall, Bucky, facing it for the first one, and then you're going to turn sideways.
Okay.
I'll be having you take in a deep breath and hold it, and then I would ask you to remain still.
Okay.
And then we'll be done with the chest x-ray. Do you have any questions?
No.
Okay. Asking your patients if they've had these exams before will let you know where their frame of reference is, and you can answer questions or help put their mind at ease. It's important that you get your patient involved in the protocol that you're going to do. You'll get their cooperation that way, and you'll calm any fears that they have. I'm going to be talking to her now about the private issues that we previously discussed. Sometimes you can ask that information while they're getting, when you take them to the dressing room, only if it's in a private situation. So we are now in a private situation. She is female. She is within childbearing age. So I need to ask her, is there a possibility of pregnancy?
No, there's not.
There's not. Okay. And some departments will have the 10-day rule, actually asking the patient when their last menses was. So if that's your protocol in your department, you will need to do that as well. Okay. And it's better to say, is there a possibility of pregnancy? If you came right out and just said, are you pregnant? Some patients may take offense to that, especially if they're younger. But like I reminded you earlier, we've seen 12-year-olds pregnant. Please keep that in mind. Special precautions do need to be made if there is a possibility of pregnancy. I would also ask the patient what her history is. Why did she go see her referring physician? Are you having any pain on either side?
Yeah, chest pain.
You're having chest pain. Where might that be?
It's all over.
And how long have you had the pain?
About a week.
About a week. Okay. She has chest pain all over. That gave me no precise information. And then I inquired how long of pain. You might ask what kind of pain, how deep the cough is, how long the cough. You also have written history that you can refer to when patients have had chest x-rays over and over again. So, device that we use. I will have my patient turn sideways and bring their arms up. Take a deep breath in, please. And I will take a measurement. You may breathe. And if you can see, it measures 19. You might ask what I'm going to do with this information. Out by the X-ray exposure panel, there should be a technique chart. In the chart, you will look up at the chart, you will find chest, you will look for chest, you will look for a PA projection, and you will look for 19 centimeters. Most charts do not have odd numbers in their setup. Most charts go with 14, 16, 18, 20. Drea is young and she's in good physical shape, so I'm going to take the 19 and round it up to 20. That tells me how deep, how big her chest is, what its depth is. And the chart will then tell me, I will look 20 centimeters up, and the chart will then tell me how much MA, time, and kilovolts to set. So after you measure the patient, you need to go set your exposure panel. So exposure panel is outside the room. We'd set those factors. We want the factors set before we actually position the patient. When it comes to do the lateral, there's two ways you can measure for a lateral or set the panel for a lateral. Again, you're going to want to measure her depth from side to side. Arms up, please. Taking a deep breath. Come right up underneath the axilla. Andrea measures 36. You may breathe and relax. I would go to the chart, look up 36, find my MA time and my kilovolts for that. Many departments don't have a technique set for a lateral. They just go with the general rule of thumb. The average body habitus, you use twice as much mass as your PA. So if we needed 3 mass for the PA, we would use 6 mass for the lateral. Kilovolts will remain the same. For chest x-rays, you want to use high kilovolts. High kilovolts will allow a low contrast level. You will see penetration throughout the lungs, and you'll see lots of the layers of the tissues, various tissues in the lungs. So high kilovoltage, low mass, very short exposure times to stop the heart motion. That you use calipers if you are setting manual techniques. Many hospitals have photo timing or automatic exposure controls. And that's another lesson in itself, but with automatic exposure controls, you select a photo cell, select the kilovolt range, backup time, and when you make the exposure, the machine will actually terminate when it reads an appropriate amount of density on the film. So you've got automatic exposure controls, you still have to set certain things on the panel, but it terminates when the appropriate density is there. Okay. Again, you set the panels before you position the patient. Okay. We need to protect our patient's reproductive organs. She's definitely under the age of 40. Female reproductive organs are the ovaries. They're the lower part of the pelvis. And she's going to be facing the wall bucky, so I'm going to put the lead behind her. And this happens to be an apron that's very convenient, and it's Velcroed. And it can just hold there. I verify that it's not too high up into the lung field, nor is it too low. It is covering the reproductive organs. Many hospitals have a tripod type device with a lead apron that's actually hanging from the tripod, and you move the tripod in to protect the reproductive organs. Okay. Now we need to position the patient. You will recall part film reference points. We're going to do the PA projection first. And the part film reference points are: the film's edge is 2 inches above the shoulder with the mid-sagittal plane to the center of the film. We need to get our patient centered. That's what part film reference points are. Get the anatomy centered to the field of view. So I'm going to focus on film's edge being 2 inches above the shoulder and the mid-sagittal plane to the center of the film. I'll have my patient face the unit, and when I use her shoulders, I'm going to be measuring from the apical region of the chest. And when you're first starting to position, using calipers like this and looking at the film's edge being 2 inches above is a very good trick to use. I want to make sure there's film clearance above the apices of the lungs, or I will clip pertinent anatomy. So I like the film height placement. If you change the film height placement, Drea, would you stand back, please, just a little bit? We need to, if we adjusted this for the patient's height, we need to verify that we moved the tube with it too. In other words, if we had to raise the unit a little bit to get the 2 inches, we would want to raise the tube so we remain with this correlation with it being centered like that. Okay? But in her case, we're going to lower the film. Okay? Make sure the film's edge is 2 inches above her shoulders. And I can actually use, you can have your patient step back, or you can leave your patient there and actually use, you know where that light was when you first set it up. So I know that I'm going to have to lower it to bring it back into the same relationship that I had in the first place. And again, the shadow of the collimated field is just within the film's edge. Okay. I'm going to have my patient put her hands on her hips. Okay. And we're going to depress the shoulders, lower the shoulders. That will bring the clavicles down from the apices of the lungs. And we're going to roll the elbows forward. That will take the scapula and bring them out away from the lungs laterally. And then I need to center the mid-sagittal plane to the center of the film. That's your vertebral column. And the trick there is to have this line come right down her spine. I can gently feel and see that this crosshair is coming right down the center of her spine. So I'm very happy with the centering. Now you need to make sure that the patient is square with the unit, that she's not turned. That's an oblique. This is not good to have. You need to have that lung square with your chin elevated to prevent the soft tissue of the neck from getting down into the lung fields. Okay. To maintain stability, we need to make sure her feet are somewhat spread, probably about shoulder height, especially when they're elderly and weak and maybe a little dizzy. Having that base of a foundation will help prevent motion. Okay, so let me recap. Her feet are spread for stability. Her shoulders are relaxed to bring the clavicles down from the apices. Her elbows are forward to bring the scapula out of the lung field. And she's facing the board straight on. That's the PC information, positioning criteria. Centering was film's edge is 2 inches above the shoulder with the mid-sagittal plane to the center of the film. Now I need to give her some breathing instructions. Before I do that, I will show you here. Her chin is not all the way up on the chest board. That's okay. A lot of patients, it will be up on the unit here, but sometimes you just elevate the chin and lean the patient in, because we want that 2 inches clearance there. I'll have you take in a breath, please. Blow it out. Take in another deep breath. Hold this one in. Keep an eye on the patient. Tell them not to move. And you go to your exposure booth outside of the room and you make your exposure. Rotor, zap. You tell your patient they may breathe and relax. And then she can, relax, because that's not a comfortable position to hold, especially when you're a beginning student. It takes you longer to position a patient. You want to build up your speed because you don't want your patients uncomfortable. Do not forget to change cassettes. Okay? We made this exposure. You'll take it to the safe place and get a new cassette and put it in the wall bucket. And if you will recall, the patient did not have pain on either side specifically. If I don't move this apron, I am not protecting her reproductive organs from the X-ray exposure. So I need to do that. The L marker is just fine where it's at because we're doing a left lateral. Okay? Have her feet spread, again, for stability. And we want her, can I have you raise your arms over your head, please? Bring them close. That's good. Can you bring your elbows in? Okay. Those are the instructions that you would give to the patient. We're going to let Drea relax for a second, though, because I don't want her to have to hold that position. I want you to practice this. Now, this is the ideal situation. Bring the patient's arms up over their head and have them grab their elbows. Now, I want you to do this to yourself. Now elevate your chin. Okay? And now hold it for the minute that it takes. You're going to find that that's very uncomfortable for some patients, especially if there's problems with muscles in the body or they're sick. So in reality, that was the textbook perfect scenario. This is probably more real world, what you're going to want to do. Elbows forward, chin up. Try to get the humerus as high up as possible. If the humerus are not up, you're going to have soft tissue into the lung fields. But there are going to be times that you are not going to be able to get that arm up much higher than this. There might be an IV pole in the room that the patient can hold on to. There might be a pulley system that they can hold on to. Be creative. Try to get those arms up. Do the best job that you can. Okay. Can we bring your arms up over your head, please? That's good. Have your patient step close to the board. Okay. Now I'm looking at her. Sometimes the hips can be wider. You don't want leaning. You don't want this scenario in any way. You want the patient very straight. But you do want the body touching. If I can only get the hips touching or the shoulders touching to keep the body straight, then I'll live with that. Keep the body straight with minimal OID. Okay. Now height-wise, Drea has not grown in the last 4 minutes, so I do not need to change the height of the cassette. But the other centering reference point is not the mid-sagittal plane for lateral, it's the mid-coronal plane. Mid-coronal plane divides the front and back halves of the body right in half. And I'm going to be looking to have the mid-coronal plane to the center of the film. She's leaning back on me a little bit, so if I can prevent that, I'm going to. Notice I just got her a little straighter rather than the leaning back. And then this cross here is going to come right down the mid-coronal plane. I look at the front shadows on the wall bucky, and I look at the back shadows on the wall bucky. That helps me centering. Again, the part film reference points. Film's edge 2 inches above the shoulder with the mid-coronal plane to the center of the film. Now I need to make the anatomy look like it's a true lateral position. That will be the positioning criteria. And to do that, the positioning criteria is I want the posterior ribs almost very nearly superimposed. To get them totally superimposed, that's the textbook perfect. But I want them as close to being superimposed as possible. So when I position the patient, I'm going to look between her shoulder blades, and I'm going to look at the small of her back. And the side that's away from the cassette, in this case Drea's right side, I want it to be just a tiny bit forward. Not totally perpendicular, but just a little bit forward, because the divergence of the X-ray beam, remember it's a divergent pattern. It starts off at a skinny beam and then it widens out. And with that in mind, it's going to take this right shoulder and project it back, and that will help you line this up. Okay? Make sure the patient's chin is up and that she's centered. Leave your room and rotors out because your technique is already set. All you have to do is press the buttons. Tell your patient that they may breathe and relax. If you noticed, I breathed the patient twice. I would like you to practice, follow my directions right now. I'd like you to take in a deep breath and hold it in. Don't breathe yet, just hold it in for a minute. Now you may breathe and relax. Okay. Now I'd like you to take in a deep breath, blow it out, and take in another deep breath yourself and hold this one in. I think most of you will find that the 2-breath motion, the method, allowed your lungs to expand even more than the 1-breath method. And your job is to get the lungs as expanded as possible. And so the 2-breath method is recommended as the better way to do that. That's not practical all the time. For instance, a patient with emphysema, you'll be lucky to get them to take in 1 deep breath and hold it. But make the attempt to breathe the patient twice. Okay? Drea, can you think of anything that we would need to add to the basic positioning protocol?
No, that sounded good.
Okay. Let's talk about some scenarios. You're going to have patients that are very large in size. You're going to think that they won't fit on a 14 by 17 film. When you think of a larger patient, you have to analyze, why are they large? Picture a 7'3" football player, somebody who's an athlete. They're tall, they're wide, they're fit. When they take in a deep breath, their lungs will probably expand off of a 14 by 17 film. Somebody who is large and who is athletic, it may be necessary for you to place the film crosswise. Okay? That will give you 17 inches of width if they're wider. So this will give you a little bit more flexible positioning. You would not use the film's edge 2 inches above the shoulder. You would put the film's edge maybe at the apices or a little bit above. Judge your body habitus and go from there, because you gained 3 inches this way, but remember you lost inches this way, and you have to compromise a little bit on that one. A female patient who's 400 pounds, your gut reaction is they're not going to fit on the 14 by 17 film either. But they're not athletically built. They're obese. It's adipose tissue. Adipose will actually take the lung fields and compress them. The lung fields are actually smaller on somebody who is obese due to extra calories rather than large from athleticism. Okay? So don't let an obese patient change your mind. Go ahead and keep the film lengthwise with the ID to the top, knowing that the lung fields are actually smaller because of the obesity issue. That's one reason obesity is not healthy for you, because it will compress the organs and they can't operate to their most efficient method. We're not talking about stretcher chest today or portable work. This was the routine, normal chest x-ray. Try to do your patients vertical at 72 inches, two breath motion. That will help that diaphragm to drop even further. When we do film critique, I'll be reminding you that you need to show the diaphragm below the 10th posterior rib. That's what you will get with a good inspiration technique. You'll be doing these patients recumbent sometimes, or on the stretcher, or in a wheelchair. But those are different lessons. Thank you.
Chest.